All right, everyone. I think we're going to get started. Dr. Marks, are you ready?
Yes, ma'am.
Okay. I am Paige Monfort. I'm a third-year medical student at West Virginia School of Osteopathic Medicine. I'm presenting on behalf of my sister, Natasha Monfort, who is currently still working and trying very hard to log on and help out, but she's listening. So without further ado, it's my pleasure to introduce Dr. Victoria Marks. Dr. Marks completed a radiology residency at The Ohio State University. From there, she completed a fellowship in both abdominal imaging and interventional radiology at Mellenrock Institute of Radiology at Washington University. In 1989, Dr. Marks joined the Department of Radiology at the University of Michigan, where she subsequently became section head of IR and director of the IR Fellowship Program. In 1999, she moved to the University of Southern California. Currently, Dr. Marks is a professor of clinical radiology as well as the vice chair for education and the director of the residency training program. Please welcome Dr. Marks.
Well, thank you very much for that introduction. What it probably tells all the people listening is that I'm really old. I'm one of the I'm one of the early wave of women going into interventional radiology, and it's very exciting for me that I think it's becoming more popular with women, and developing a residency where we can recruit people straight out of medical school, I think will also increase our ability to recruit women into the field. So what I'm going to talk a little bit about today, and I think this is a small enough group that if you do have questions, you can chime in and ask, and if it does kind of get too complicated to do that, then I'll change my mind and say so. The topic is unique risks for women working in a radiation environment, and let's see, how do I, there. I'm going to talk about the risks that women care about, and one of them is that every once in a while we have to do procedures on days we didn't wear gym shoes, so I have actually done TIPS procedures in high heels. This is an example of that. I don't recommend it, but it can be done. Things that we also have to worry about are bad hair days because of the surgical hats we have to wear. Lost earrings. I've lost many earrings by ripping off a poofy surgical hat and not noticing that the earring went with it when I threw it in the trash. Bad nails. We have to wash our hands so much that we always have bad nails. You really can't handle a manicure very well. Bad skin. I have chronic skin irritation from all the hand washing we do and the chlorhexidine in particular. And ruined knit clothing. If you ever have a wraparound lead apron and you're wearing knit clothing, you will ruin your knit clothing with the Velcro. But my guess is that this isn't what you came here to listen to. The real thing that people are worried about is pregnancy. How do you manage pregnancy and working in a environment that has occupational exposure to radiation? And pregnancy is a very interesting topic in the United States today. It's very politically charged. Here was the House Oversight and Government Reform Committee in 2012. This group of men was telling this young woman, you know, why she shouldn't have birth control as part of her health insurance. And here's a recent thing, this just happened this year, that the CDC recommends that sexually active women who aren't using birth control should never have alcohol. And I mean, some of these attitudes are remarkably invasive into women's decision making and really inform all of our kind of decision making about pregnancy. So let's talk a little bit about the background fetal risk of having a health problem at birth. So, and this has nothing to do with radiation, right? So the risk that a baby will be born in developmental retardation is about 1%. The risk of being born with a major congenital malformation is about 3%. The risk of having growth retardation intrautero that affects later life is 3%. Premature births take place in 7% of pregnancies. Some sort of genetic disease is present in 10% of the population. Spontaneous abortions affect 15% of pregnancies. And the lifetime risk of fatal cancer in the U.S. is about 21% of people. So that our background risk of some sort of a bad outcome related to at birth or later in life is actually relatively high. So because of that, and because we have a very risk-averse society, and because pregnancy is somewhat political, society tells women to avoid an enormous number of things during pregnancy. And this was a website that I visited, www.pregnancy.org. I visited this website, and this is the list of things that women who are pregnant should avoid. And the one thing that they recommended that I found particularly interesting was this. They said, don't overheat. Check your core temperature during workouts every 20 minutes using a rectal thermometer. This is the kind of information that women are getting. What if you're in a class? I mean, this is ridiculous. So that's the background that we, not me anymore, I'm too old to have babies, but that women in this generation have on their minds when they're trying to make decisions about behavior during pregnancy. So now I'm going to give you the physics course. Radiation dose units. The unit that measures absorbed dose in matter, like tissue, is called the gray. The sievert is a measure of occupational dose that takes into effect the biological effect of the dose. So the biological effect of radiation to cells that are rapidly dividing, say in the GI tract, is going to be different than the biological effect of that radiation in, say, the brain, which doesn't do much besides think, so that the sievert will take those differences in effect into account when it makes its number. And the sievert is used in assessment of low dose exposures and occupational dosimetry. And physicists would very much object to this, but for purposes of this talk, absorbed dose in real life, the milligray, because the gray is really a huge number, so we talk in milligrays, is effectively equal to an occupational millisievert dose, just because you may see both of these numbers in the talk and in life. But in general, you can kind of think of these as being equivalent. So what is the background radiation in the United States? Well, natural radiation from cosmic sources and from radon coming up from the ground is about 3 millisieverts per year. Man-made radiation, which is mostly medical in the United States, is also about 3 millisieverts per year. Now, obviously, there's wide variability with that because some people get 10 CT scans in a year and some people get none, but on average, for all the people in the United States, the total background radiation is about 6 millisieverts per year. So that's kind of a number that everybody's getting whether they're pregnant or not, basically. Although if you're pregnant, you're on the lower end of that because you're probably not getting CT scans. So what are the regulatory dose limits regarding occupational exposure? The annual public limit is 1 millisievert per year. So going from somewhere between 3 and 6 millisieverts per year background to 4 to 7 millisieverts is the annual public limit. And this is the radiation exposure that's okay for anybody in a hospital who's, say, walking down a hallway in the radiology department, a public person in the public. So the walls in the radiology department are very well shielded. The annual occupational limits in the U.S. Are 50 millisieverts for the total body effective dose, 150 millisieverts for the lens of the eye, and 500 millisieverts for the skin on the hands and the feet. And the reason for these differences is that the effective dose for the total body is kind of the average dose of the entire body gets. And if you're really working in an occupational radiation environment, you have lead that is covering a lot of you. And the reason that we don't have lead covering our hands and our feet and our lower legs and our arms is that the tissues in those parts of the body are relatively insensitive to radiation. In adults, there's really no bone marrow in your fingers, and skin doesn't divide and change that rapidly, so that the likelihood of any ill effects is very low. So background radiation, we're going to say, is between 3 and 6 millisieverts per year, and you can see that the these are really tiny numbers because the occupational dose limit to the total body is an order of magnitude greater than that. Now, what about the embryo and fetus? Well, the embryo and fetus is rapidly dividing, so that the limits are lower, these regulatory dose limits. And there's more than one way to think about it. By the NCRP, the National Council on Radiation Protection and Measurements, says that the dose limit for an embryo or fetus should be 0.5 millisieverts per month. The NRC, Nuclear Regulatory Commission, basically does that, multiplies that by 10, the number, roughly the number of months, and says that the limit should be 5 millisieverts for the entire pregnancy. And in Europe, the ICRP has their regulatory dose limit as 1 millisieverts for the pregnancy, and their rationale for that is that the fetus, the unborn child, is basically a member of the public, so that the dose limit should be the same as the dose limit for a member of the public. But overall, these doses are very low. So what are the actual documented ill effects of fetal radiation exposure? They're orders of magnitude greater than these dose limits, okay? So at the ill effects during the first month of gestation is basically death. It's an all or none thing. There really aren't that many cells involved. And the estimated threshold dose, now this is milligray, not millisieverts, is 100 to 200 millisieverts. So it's 2 orders of magnitude greater than the dose limit. Between 4 and 8 weeks gestation, this is during the major part of organ formation. The ill effects would be malformations and growth retardation, and the estimated threshold doses is 200 to 500 milligray. During the 8 to 15 weeks, all first trimester, the ill effects that are documented are growth retardation, severe mental disability, or microcephaly, and again, huge radiation exposures, well above what you see in an occupational setting. And then for the rest of the term, the ill effects are really because the body's basically made, it's just growing. The ill effects are severe mental disability, again, a large dose and a decrease in IQ. And there's no recommendations in the medical physics community or radiation biology community for therapeutic abortions below a very large dose, below like 100, I don't know the exact dose, but up in this range, not an occupational dose. So in trying to put our fears of radiation and put them together with what we know about radiation effects and what we know about suboptimal pregnancy outcomes in general. This is a chart that was put together by a medical physicist who's still very active in the field, looking at the dose to the fetus above background in milligray and the risk of having no malformation or childhood cancer. So if the fetus has no radiation above background here, then the likelihood of being born completely normal, no malformation or childhood cancer, is about 96%. So there's about a 4% risk of a malformation or childhood cancer with no occupational radiation exposure during pregnancy. And then if you take it to 100 milligray, the risk goes basically from 96% likelihood of being normal to 95% likelihood of being normal. So what this chart is saying is that even as you go higher with doses, the risk to the fetus is very, very low. So there have been some work in real life looking at women's radiation dose. Now, one thing I ought to emphasize to you is that the fetal dose is not the collar badge dose. It's not even the waist badge dose, because the adult mother's body adds another layer of radiation protection to the developing fetus. But here's some stuff. This is Lou Wagner is a medical physicist who's done a remarkable amount of work looking at occupational radiation exposure and interventional radiology. I would just look him up in PubMed, and everything he writes is very, very excellent. But he had 2 residents in his program. I think he's at UT Houston. And this is fairly old, but he looked at their collar badge readings and their waist badge under the lead readings for 2 pregnant radiologists. And what you saw here was that the collar badge readings were in milligray, had numbers, but that under the apron at waist level, the radiation above background for the most months was too low to detect. So that's what all these M's are, is minimal, too low to measure. And so these women were working, and they were wearing lead, and the lead worked, right? This is a study that I did back in 1992 when I was a young interventional radiologist contemplating pregnancy. I enlisted 30 interventional radiologists who wore collar and waist dosimetry badges for 2 months. They also answered a questionnaire about their work. And what we found was that their mean, what we did was, on that 2 months, we did a projected yearly dose under the apron. Their projected under lead dose for a year was 0.9 millisieverts, which is approximately the same as that 1 millisievert fetal dose limit set by the ICRP in Europe, which is a little more conservative than the US. And if you looked at the difference between a 0.5 millimeter lead apron and a 1 millimeter lead equivalent apron, people with the 1 millimeter equivalent lead apron, that dropped down to less than half of the average. And the this basically is the same as what most maternity aprons are, is a millimeter thickness of lead. So I was very confident, based on my own research, that I could safely manage occupational radiation exposure with a double thick lead apron. There was a study presented at the SIR in 2014 looking at reviewing the dosimetry on 2 pregnancies in 1 interventional radiologist physician, and what they found was that they had basically the same as the NCRP regulatory limit under the lead apron per month. Under lead dose average was a little less than 0.5 millisievert a month. So what do these studies all mean? You know, these are small numbers, but they're real life. Well, my conclusion is that pregnant physicians can practice in a fluoroscopic environment and comply with U.S. regulatory limits on occupational radiation exposure. What makes it complicated is that is a completely rational statement. And what we each have to decide is meeting regulatory requirements safe enough for me? That's the question that each woman has to ask. And what do I need to do to live without regret? Because there's about a 5% chance that a child being born will have some sort of health problem that they have to deal with, and that you as a parent have to deal with. So that's the thing that nobody can really regulate, you know. So here's what I did. When I decided to get pregnant, I put an extra piece of lead, taped it to the inside of my apron over my pelvis. And what that did was reassure me that I was doing what I could without having a huge maternity apron to protect the fetus during the very, conception, basically. And doing this meant a couple of things about me, one of which was that I wasn't trying to hide the fact that I was getting pregnant. Nothing was private about this, and that just is me. The other thing is that I was also in a position of some authority when I decided to try to get pregnant. I was already an attending, and I knew that I wouldn't have my back to the fluoro when somebody else is fluoroing, and I wasn't going to be the assistant. I was going to be the person in charge during cases, there's an element of when you're in a position of authority that you can control your situation a little bit more than when you're a resident or a fellow. So that was what I did, and here I am laughing, showing where this piece of lead is on the inside. And then later on in my pregnancy, I actually had a custom-made maternity apron because I'm very short, and the standard ones protected me from like the iliac crest down to my knees with the double lead, not really over my abdomen. So I had a custom-made lead apron and wore that for the rest of my pregnancy. And it was double, it was a 1 millimeter thickness in the front and the sides. And again, it wasn't in the back, and again, I wasn't walking around getting fluoroed in the back. So I also did some work modifications. I intentionally did not learn new procedures. And the reason for that was not really all the radiation exposure. It had to do with just the length of time in the room, the physical requirements of learning a new procedure. The big new procedure that was being learned by everybody at the time I was pregnant was TIPS. And early on, TIPS took a lot of time to do. So I just was the last person in my group to learn how to do a TIPS procedure. What I did in exchange, because you can't just work in an environment collegially and say you're not going to do things, what I did in exchange was that I did a much larger percentage of the routine small cases than I would have otherwise done. I intentionally did not take call after kind of midway through the pregnancy, and the reason for that had nothing to do with radiation exposure. It had to do with the my own physical issues, which were that I had a lot of premature contractions that were definitely physical, work-related, and I just needed to have more time off my feet. But in exchange for that, I took over some of the administrative and education duties. So I was doing all the scheduling, and I was doing the conferences for the residents and that kind of thing. And then another thing to think about is, and this isn't unique to interventional radiology, I think it's unique to many, many occupations, is you have to stay hydrated. So you can't get so distracted working hard that you forget to drink water. So I drank lots of water. This is my son. He's perfectly normal, although he doesn't quite look so here. He doesn't have dreadlocks anymore. And I have 2 children. So there's a lot of things now that people can do to decrease their radiation exposure occupationally, and it's very interesting because I'd say our current trainees are much more risk averse than people in my generation, and our current fellows and residents are teaching increasing attention to paying attention to ways to decrease occupational exposure to the attending. So the impetus for utilizing some of these extra means to decrease occupational exposure is coming from the younger people in the division. So we have table-mounted shielding that limits the scatter exposure from the tube. It looks like the flaps in a car wash thing. Flexible lead shielding that kind of hangs down between your legs and the side of the table. We have boom-mounted shielding that's clear that you can put in between your upper body and head and the image intensifier in the patient, and that's useful not only as a radiation shield but as a splash shield. We have disposable sterile shielding to put on the patient. The RadPad is the proprietary name, and they're very useful to decrease scatter from the patient. We can use decrease fluoroscopic frame rates when we're doing long procedures and really don't degrade the image quality significantly. It still lets us do what we need to do. We have a fluoro save feature on the monitors where you can tap fluoro, get an image, and not have to do live fluoro to really look at it and decide what to do next. We have last image hold. There's now a robotic angio catheter control system. It's not widely used yet, but I think in the future it will become more widely used. And they're working on it now to have microcatheters that can be controlled robotically. It's a really exciting feature that I think will over time become more widely available and more streamlined. What the it's like in its it's a 1.0 thing now, but by the time you guys are my age, you'll all be doing this stuff with robots. This is just an example of a setup. So here's the table-mounted shields. The X-ray tube is kind of behind here underneath this medical student who's posing as a patient. She's got her wraparound lead apron on, her thyroid shield. She could wear lead glasses, but you don't really need lead glasses if you're using one of these boom-mounted shields. She's keeping the image receiver very close to him to decrease scatter. This is a rad pad that you can put on the patient. There's all kinds of things you can do to really have your collar badge even say there's no radiation exposure. So in conclusion, in the big picture, the background risk of having some sort of unfortunate outcome to the fetus is relatively high, roughly around 5%. Fetal radiation dose below which no ill effects occur is not known exactly, but it's estimated to be about 50 to 150 milligray or millisieverts in the occupational language, which is way below what you get in the occupational environment. Maintaining occupational fetal dose within regulatory requirements makes the likelihood of radiation-related ill effect vanishingly rare. In fact, there really are no cases where there's been documented cause and effect with radiation and an ill effect on a fetus. And managing response to that risk really is individual. Nobody can do that for you. And what I hope I have done is been somewhat reassuring in the fact that our concerns about radiation are somewhat exaggerated and fit into our overall paranoia about pregnancy right now. And that's all I have to say. Thank you. I'm happy to answer questions. Is anybody there?
I'm here. I know that some people are muted. I'll
Muted. Unmuted.
Hello.
That's Natasha.
Can you hear me now?
I can hear you, Natasha.
Okay, Dr. Marx, thank you so much for giving this webinar. I really appreciate it. I know that this is a common concern for women, and I get asked this question on a regular basis, being the chair of Women in IR. And recently, when I was at SIR a couple weeks ago, we had a Women in IR meeting, and they had a discussion about how multiple of the female attendings had double-leaded all through their entire pregnancy up to, about 38 weeks when they, essentially stopped working then. Is this something that you think is necessary, or do you think that, with the fact that we have different lead, we can get pregnancy lead and that kind of stuff, it's not as much of a concern and it shouldn't necessarily be an issue?
Hello?
You can talk.
I'm not sure I understood the question.
Well, I feel that there's such a big concern with radiation in pregnancy, and every female attending has done it differently, but a lot of them are saying that you should double lead and wear double lead up to however long you work, and
well, that's what I did basically, right? So I put, when the pregnancy was little, my double lead was small, and when my pregnancy got bigger, I had a standard maternity apron. Now, by double leading, are you saying taking 2 wraparound aprons?
Yes.
Well,
and go ahead.
A lot of that is peace of mind. So I would say that to me, it would make more sense to design an apron that gave you 1 millimeter thickness. Body is going to protect you from the back, and you're mostly don't have your back to the tube, to the X-ray tube. My guess is they were using double lead to have 1 millimeter thick in the front and nobody thought to have a custom-made lead apron that did that.
Okay, hold on. I think she got muted. Hold on. I can't find her.
I haven't touched anything.
Natasha?
Yes.
Okay, go ahead. Sorry.
I don't know how I got muted, but I did. But
I don't know.
Did what I say make sense?
Yes, it does. I feel like everybody is very concerned about this, and SIR hasn't put out any consensus guidelines on how to deal with pregnancy and all of that.
Well, I think the reason that people hesitate to put out consensus guidelines is because of the issue I bring up, which means that where women have to decide for themselves. I think it's the women in IR section may take this on because I think it is an area of increasing concern. And I think that the best lead solution would be to have a millimeter thick in the front and around to the side, and then a half a millimeter in the back, because it's just not necessary.
Okay, makes sense. Outside of the radiation and pregnancy, can I ask you how you balanced work and raising children and life in general?
So, yeah, so a couple of things. My husband and I are both very involved parents, and we're very on the same page and collegial with each other. We also threw money at child care. So when our children were little, we had an in-home babysitter. She didn't live with us, but she came early in the morning and stayed till one of us got home. And then the way we were having babies before nanny cam, so we had a live nanny cam initially, which was family member, an extended family member who, when we first had the babysitter, would drop in unexpectedly, you know, so we sort of had some peace of mind that that was going okay. We sort of we always stayed in close touch. We tried not to be on call at the same time. We tried to make sure somebody was going to get home by 6. We, you know, spent all our time with didn't bring work home. And I worked, when I moved to Los Angeles, I had the good fortune to join a group of people, and we all sort of had kids around the same age, so that we all had each other's back. So if somebody needed to leave to go to a recital, we all took turns covering for each other. So a collegial work environment was also very helpful. I never went part-time until one of my children was developing some at-risk behavior in his teenage years, and so I cut back a little bit while my husband and I sorted out that, and you know, that all worked out fine. Then I went back to full-time. What else? Is any of that helpful?
Yeah, it's wonderful. It's nice to have somebody else's perspective, because I'm not kidding. I get asked this question on a weekly basis, and
yeah.
I don't have children yet, and I'm still very junior in my career. I mean, I'm only in R2, soon to be R3 in a couple months, and I can't wait to get into IR and start being in the lab all the time. But, you know, this is a concern that I have, and I know it's a concern that a lot of women have, and so it's nice to hear that somebody who's been as successful as you are has done it. And has been
well,
able
you can't.
To
you gotta try not to be too perfect at everything. That's for sure. You know. So like, you know, I don't know. We always had a messy house, but everybody was having a good time. You know, you can't try to be too perfect. The standards for parenting right now are very high. I don't know that they were as high when I was having little kids. And I frankly think that the need to spend time with your small children is less than your need to spend time effectively with your teenage children. Because when children are little, they like you no matter when you show up. But once you get teenagers, just because you show up doesn't mean they have any interest in you. So my husband and I both found the need to kind of cut back on career growth and concentrate on family increased as the kids got older, you know.
Very interesting. There's a question from the audience. It says, is there any data on IR's occupational exposure compared to other specialties?
I don't know of any data that's direct. Now my guess is there's a lot of information out there. I'm sure there's a lot of work that's been done looking at interventional cardiologists and their occupational exposures, so I'm sure the information is there, although it might not be in one paper. One person who's done a lot of work and written a lot on occupational exposure in both the radiology and the cardiology world is a physicist named Stephen Balter, B-A-L-T-E-R. And searching his name in PubMed might come up with some resources in that respect.
Okay. There's another question that says, can you discuss some techniques in talking to medical students and early trainees to help mitigate concerns about radiation exposure?
Well, I think along the lines of what I've tried to do here, just to put occupational exposure in some sort of context related to background radiation exposure and what the data is about the ill effects of radiation. I think that's the best approach, and also leading by example, I guess. I mean, the more women we have who can tell our stories, the better, and I think that it's should be a huge focus for the Women in IR section coming up in the next couple of years, that they can develop some messaging and communication tools for this particular communication challenge.
I know that was one thing that we discussed at the Women in IR meeting, is coming up with recommendations, or just kind of getting our stories out there so other people know and understand that this is how we did it, it's kind of how we made it work, and it may not have been perfect, but this is how it was. So hopefully shortly we'll have some sort of, not necessarily guidelines, but
yeah. No, I think that's great.
There's another question that says, any thoughts on the difference of background radiation at elevation, for example in Denver, versus average IR occupational radiation?
Well, people at high elevation are going to have a higher background radiation exposure, so that but it's also small. I mean, I just think, so are you saying that is the patient risk higher if you work in Denver than if you work in Jacksonville, Florida? Yeah, is that, I just don't think it's a significant difference.
Okay. I don't know if that answers her question, but we'll see if she types another question or types more to us. The next question is there any data on ergonomic risks for female IRs, i.e. being shorter than the equipment is designed for, face and neck more in the scatter zone?
Well, so those are two different. So ergonomics have to do with, your body position, and there are papers, not in women specifically, but there is some literature suggesting that wearing lead long term is hard on the back and the C-spine and L-spine, and a lot of that is why people now are wearing, instead of just one lead apron that hangs off your shoulders and you wear in front that's very kind of unbalanced, that everybody now wears skirt and vest, that where the weight is divided between the shoulders and the pelvis, and it's circular around your body. Part of the reason to have it be circular is just because it's more even and ergonomic. And then there's you try to develop good work habits where you're not doing a procedure and staring at a TV screen over your shoulder all the time. You position things so that you're looking straight at the TV, and you're working I do this all the time. I make sure that the room is set up so that it feels comfortable, and the IR suites are really designed to be maximally flexible, so that's not typically an issue. Now, the issue of being short and having your head closer to the X-ray beam, there's really no data on that, but all of that can just be minimized by the use of all this the idea that you've got higher scatter to your head and eyes if you're short than if you're tall is probably true, but it can be mitigated very easily by all the ancillary ledge to boom mounted shield, the patient mounted shield, the table mounted shield can completely negate any of that. I'll tell you, I've never had an ergonomic problem, but one time, how residents evaluate faculty members all the time. I got one evaluation once where a resident, and I think I know who it was, but I mean it was an anonymous thing, but he said he had terrible back pain after he worked with me on long cases because I was so short and I was the one in charge, so the table was where I wanted it to be and he had to bend over.
I think that's how part of paying your dues as going through residency, because I remember being on surgery and having to hold for a mastectomy, and my surgeon was 6'7", and I'm 5'5", yeah, maybe, and I'm like arms above my head on 2 stools. So
right, yeah.
There is another question that says, recently a male attending told me that I should consider freezing my eggs, especially if I plan to pursue IR. What is your opinion?
He's nuts. That's crazy. Freeze your eggs for what? For when?
Yeah.
That's just nuts.
I also recently read on, there's a Women in Radiology post online or on Facebook that people just post questions, but there is a girl who took 6 weeks maternity leave during her residency, and now the ABR is not letting her sit for boards because she's been off too much, even though she's under the guidelines as far as how many days she could miss for her program. Any recommendations?
Yeah, so here's the thing, is that the American Board of Radiology has very specific requirements to be eligible for sitting for boards. So in my program, my residents are given 24 days of vacation per year, and they're all employees of the County of Los Angeles, so they also get 8 sick and personal days, which adds up to 32, okay? But the American Board of Radiology says that by the end of your first year of radiology residency, you can't have been off more than 30 days. By the end of your second year of radiology residency, you can't have been off more than 60 days. By the end of your third year, you can't have been off more than 90 days, and by the completion of residency, you can't have had more than 120 days away from service. Now, probably this woman who took 6 weeks off did it at a time period where it put her over one of those milestones. Mm-hmm. And the program director has to abide by the American Board of Radiology rules. So she'll be able to. So she'll be able to sit for her boards, but it'll just be late.
Fair enough.
But those requirements are written out very specifically on the ABR website.
Okay. Well, I haven't seen any more questions come through. If anybody else has questions, please unmute yourself and ask. If not, you can type them in. We'll give you another minute or so to type in another question. If not, we will thank Dr. Marks and let her get on with her night.